Kia ora tātou. Hello and welcome. I'm Adele Gauthier, Research Manager at Breast Cancer Foundation NZ, and today we're talking about male breast cancer. Because most breast cancer affects women, those men who are diagnosed can struggle to find information specific to them and to find other men to talk to. Hopefully we'll address some of those issues today. We're going to hear from three speakers: a patient, Greg Sargent, Mr. Wayne Jones, a breast surgeon, and Nurse Judith Beattie from here at Breast Cancer Foundation. So first, let me introduce Greg Sargent. He was diagnosed with breast cancer in 2016 and found himself in unfamiliar territory. Greg, thank you so much for being with us today. You've been very generous in the past about sharing your breast cancer experience with other men. Can we ask you to do that one more time for our audience tonight?
No problem. Okay, I was diagnosed in 2016, as mentioned, at the age of 64. Initially misdiagnosed as bruising. They thought I banged it against a car door. This is a common problem with other men, that we get diagnosed initially as bruising because it's very low on a GP checklist that we're going to have breast cancer. Went away to Europe for 3 months when it fungated, which meant it started to ooze fluid. The nipples started to ooze fluid and I had to get it dressed. And when I got back to New Zealand, I got off the plane the next day, saw the doctor, went to biopsy, and they found confirmed stage 3 breast cancer. And in the end, I had a 4-centimetre tumour. So that was the diagnosis, not as smooth as it could have been. Initially, I had to come to terms with having a woman's disease. I know I don't want to be disrespectful to women, but as a man getting breast cancer, because you hear so much about women's breast cancer and so many women get it, it's like, why me? Why have I got breast cancer? You know, I only have 2 rather modest looking breasts here. So I went to counselling. First of all, I had private counselling to go through it. And then when I came back to Auckland DHB provided me with some counselling, which was very good in terms of getting your head around the fact that it is just a disease. It's just a cancer. And that was what I had. And it was nothing to do with women. It wasn't anything to do with anything else. I got cancer in my breast and that was it. So we went through a lot of stuff around that, which was very good. But still got men asking me, how do we get breast cancer? And in fact, one guy at one clinic said, where do we get breast cancer? So, you know, there was a lot of, when I told my friends, family, and some people I knew, a lot of them didn't realize that men could get breast cancer. So that was quite a big wake-up call for me, and I think for a lot of other people. So yeah, that was some interesting times. So I had a mastectomy at Tauranga Hospital. Dr. Peter Chin was brilliant. I had 13 lymph nodes removed. I was lucky. They only found cancer in one of the lymph nodes, which was in the primary lymph node. So it hadn't used the lymph system to spread anywhere else. That's what they told me, but I had 13 lymph nodes removed. I didn't get lymphedema, but I'll talk about that later on. But I had 16 cycles of chemotherapy, which was difficult. There's something at the end, I'll talk about ports and hands, but what I did do, and don't ever talk to an oncologist about vitamin C ever curing cancer, but I did have major vitamin C infusion programs to help my immune system and to deal with the chemotherapy. It worked. It made my trip through chemotherapy a lot easier. That meant I was having in a sitting up to 85 grams of vitamin C over 2 hours. And that really worked well. The wig lady was an amusing interlude when you're having your chemo, because they would come around and give lots of ladies wigs, but they didn't have one for me, which there we go. I'd had my head shaved anyway. But anyway, 4 rounds of radiation, that was quite painful. I had severe exit burns, but the medical team and the nurses were brilliant, and I got that dress. So that was just, again, part of the treatment. I've been on tamoxifen for 5 years, which is the estrogen drug which stops cancer cells eating up my estrogen and creating cancer. The tamoxifen side effects were hard to deal with, and I was taking, I can never say this, escitalopram for mood, because I got very bloody and very hormonal and whatever. I finished taking tamoxifen this June when I came out the system, but I'm having trouble getting off the mood balancer, because when I came off it, I actually got quite depressed and I got quite angry. I've never had road rage in my life until I came off this. And I've actually managed to get mammograms now going forward. So that wasn't available when I started my treatment. And I've had several mammograms now on my left side, which is quite reassuring. What would I have done differently? Followed up on the initial bruising diagnosis sooner, but I didn't know, I was ignorant. All the men I met were initially diagnosed with bruising, and that's every man I've met who's had breast cancer was initially diagnosed with hematomas or bruising. That's quite important point there. So if you do get something like that, follow up on the diagnosis. I should have had a chest port for the chemotherapy, because putting it into the back of my left hand 16 times, but towards the end, it took them an hour to find a vein, and they were putting my hand in boiling hot water to get the veins up. I would have done that a lot differently. Not much else. I have to say that the health system has treated me well. You hear a lot of gainsaying about the health system in New Zealand, but I have to say that I've been treated well. I've had support when I've needed it. And I think at the end of the day, it's hard we've just been talking earlier before we came onto this about being in such a small group of men, of actually being able to share our experiences. I do have somebody who I can do that with. And we just talked about a support group that exists in Tauranga. So it is hard. You do feel a bit alone. In the clinics, you feel a bit isolated. It's very lady focused, but all I can say at the end of the day, it's all in your head. If you can attack it positively, then you will get through it. There we go.
Great. Okay, thank you so much, Greg. But now we're going to hear from Mr. Wayne Jones, who's a breast surgeon at Auckland City Hospital and in private practice here in Auckland. Wayne, thank you for joining us. Can you tell us what's different about men's breast cancer rather than women, and how do we go about treating it here in New Zealand?
Okay, well, thank you, Adele, and thank you for asking me to join the panel. Greg, thank you for the story. It really makes it much more real when you actually hear someone tell you about their experiences. So male breast cancer is a rare cancer. Of all the breast cancers that we see, for every 100 breast cancers that we see, less than one of those is in a man. The incidence or the rate of breast cancer is about 1 in 100,000 men per year, but the problem is this rate is increasing. So we're getting more and more men with breast cancer. And in New Zealand, we get about 25 new male breast cancers each year. Now, the Breast Cancer Foundation funds a national registry. That's been going for some years now, and there are 197 cases of male breast cancer in the registry. 80% of those men are European, 5% Maori, 6% Pacifica, 7% Asian. Interestingly, the mean age of diagnosis is 68 years, which is about 10 years older than the age that women are diagnosed. And genetic abnormalities are important in male breast cancer. With the BRCA2 mutation, if a man carries that, and a man is as likely to carry a BRCA mutation as a woman, there's about a 6% lifetime risk of getting breast cancer. And for the BRCA1 mutation, if you carry that, there's a 1% lifetime risk of getting breast cancer. So what causes breast cancer? Well, we don't really know, but in men, it does seem to be related to estrogen levels and sometimes what's called testicular failure. So the testicles aren't working as well. There are some occupations where there's an increased risk. For example, men who work in areas where there are high temperatures, such as steel factories and blast furnaces, or exposure to chemicals in the petrochemical industry, such as perfumes and soaps. And in the past, radiotherapy has been used to treat lymphoma, and also, interestingly, been used to treat gynecomastia, which is male breast tissue. And unfortunately, over time, that does increase men's risk of getting breast cancer. And if you're taking estrogen supplements to treat prostate cancer, or you're taking estrogen in the situation of gender reassignment for transgender women, that also statistically increases the risk. And if there's any cause of testicular failure, such as mumps or undescended testes, or your testicles have been removed, which is what orchidectomy is, that increases the risk as well. So this table shows what's called the relative risk. So the increase in risk associated with these particular factors. So if you have a family history of breast cancer, as a male, your risk is increased 2.5 times. And if you've got the BRCA2 gene, 50 to 60 times. And Klinefelter's syndrome, which is a syndrome where men have 2 X's and a Y chromosome, it's increased 20 to 50 times. And as you can see, there are the other causes are listed there as well. What we do know, as Greg discussed, is that men tend to present later with more advanced disease. And unfortunately, men have their symptoms for 6 to 10 months before the diagnosis is made, on average. Most men present with a lump, but they can present with nipple changes and breast pain. And as in Greg's case, a large majority present with advanced stage 3 or stage 4 disease. How do you make the diagnosis? Well, we need to rule out other causes of breast lumps, gynecomastia, which is benign male breast tissue, or other benign tumours on the chest. And as we've heard, men can have mammograms and ultrasounds, but the diagnosis depends on having a core biopsy, which is done under local anaesthetic, just in the hospital clinic. The pathology of male breast cancer is a little bit different to female breast cancer. And that in men, most cases, 90% are ductal cancers. And lobular cancers are very rare. The reason for that is that men have breast ducts in behind the nipple, but they don't develop lobules or gland tissue, so they don't get lobular cancer. 90% of them are estrogen receptor positive. A few percent are HER2 positive, and a very small minority are the nasty triple negative breast cancers. How do you manage them? Well, there's very little research that's been done on male breast cancer, again, because of the low numbers. But what we do is we extrapolate from what we know about treating female breast cancer. Men tend to have smaller breasts, and therefore most of them have a total mastectomy, and that's where we remove all of the breast tissue with the surrounding fat, including the nipple and the lymph nodes if they're involved. We also do a sentinel lymph node biopsy, just as we do with women, and that means taking out just 1 or 2 of the lymph nodes, checking those, and if they're negative, we can leave the lymph nodes behind, although as in Greg's case, if the lymph node is positive, you'll want to take out other lymph nodes as well. Sometimes we give chemotherapy before the surgery, and that's called neoadjuvant chemotherapy. If the cancer is proven to be a HER2 positive cancer, or it's a triple negative cancer, or it's particularly large, so large that we can't operate unless we shrink it down with chemotherapy first. And then after surgery, we always consider chemotherapy, hormone therapy, and radiotherapy. And again, we decide on this treatment based on the grade of the cancer. Is it a slow-growing cancer or a fast-growing cancer? The size of the cancer, and whether the lymph nodes are involved or not. And you heard Greg talk about having chemotherapy, and that's probably because of the size of his cancer and the fact that he did have a lymph node involved. And the mainstay of treatment is tamoxifen, as Greg had, generally 5 years, or for higher risk cancer, maybe 10 years of treatment. And what this drug does is it stops the estrogen feeding the cancer cells, so the cancer cells die. It's thought to have less side effects in men than women, but men still, well, Greg may disagree, but men still have hot flushes, and men do have sexual dysfunction and loss of libido by taking tamoxifen. After the other thing that's been used are drugs that block the androgen or testosterone hormones in the body. And interestingly, when you look at male breast cancers, nearly 90% of them have the receptors on the surface for testosterone. And so we've known about this for a while. And in the past, for people with metastatic disease that had spread, they had removed the testicles to decrease the amount of testosterone. And there are drugs that can do the same thing. There are also some new drugs that are used in BRCA patients, and a particular group of these are the PARP inhibitors, and they can be useful in men just as they are useful in women. But there are particular issues with male breast cancer. First thing is we do need to consider the possibility that a man with breast cancer may have a genetic abnormality. And if they do have a gene abnormality in the BRCA2 gene, they're also at increased risk of pancreatic, prostate, and melanoma. So men need to know that, and they can pass that gene on to their own children, their sons and their daughters. As Greg said, men often find it difficult to make sense of the diagnosis, and it just it can be a hard thing to get your head around. And they do have concerns regarding masculinity. They're coming to a breast clinic surrounded by women. They're going through a mammogram, having a mammogram, which they never in their wildest dreams thought they'd have to have. And as Greg said, they have the stigma of having a woman's disease. And this does cause significant distress. About 25% of men with breast cancer do suffer from anxiety and depression. There can also be difficulty interacting with health services because it's deemed a female illness. And there are concerns regarding body image and asymmetry. And it's important to ensure that we do provide our men with breast cancer with the appropriate psychological support. And we also can do breast reconstruction for men as well. We can use chest wall implants, we can tattoo the nipple, and make things look perhaps a little bit normal if they wish. And certainly for those younger men having chemotherapy, we need to think about fertility and sperm banking. So how do men with breast cancer do? Well, the prognosis of male breast cancer is the same as that in females for cancer that's the same size and the same stage. But the problem is they do present a bit later. But overall, most people do very well. If your nodes are negative, you've got a 90% chance of surviving. If your nodes are positive, overall, a 65% chance of surviving, but those odds are improved with treatment. So in conclusion, we don't know much, we don't know enough about male breast cancer, and we have to extrapolate from all the studies on female breast cancer. It does present later and can have a worse prognosis because of this. And we're guessing a little bit about the biology of the disease and the response to hormones because it may be different than in our female patients. And it is important to consider the special psychosocial issues that our male patients face. Thank you.
Great. Thank you so much, Wayne. That was extremely helpful. Our last speaker, who is Judith Beattie. She's a nurse here at Breast Cancer Foundation. Now, if you've ever phoned our 0800 support line, you might have spoken to her. Judith, from your perspective, what are the important things that men diagnosed with breast cancer need to know, and what advice do you have that might help them?
Thank you, Adele. Well, as we've heard from Greg and Wayne, any cancer diagnosis is a shock. And when you have a type of cancer that's in a minority, it can be really hard and isolating because you've probably never met another man that's had breast cancer or even known that men can get breast cancer. And as Greg alluded to, everything is very pink in the world of breast cancer. We're very lucky that we have a high public profile and that lots of people know about us, but it is associated with women. And so it's really hard when you have this disease that everyone associates with women. How do you explain it to friends and family? I've got the little picture of the breast tissue there, and as Wayne said, men and women have exactly the same biology, only our female hormones allow our breasts to develop, and men still have breast tissue, but it doesn't develop. So for some people, you might need to explain that, the structure, that everybody does have breasts. And the other thing is, who are you going to tell? And as Greg said, he has one friend that he talks to about it, and he told me before that he's been to a group which he actually found a little bit depressing. And I know that sometimes men don't always want to group together and talk the same way that women do, and that a male breast cancer support group might look like a group of guys talking about sport, drinking a beer, and then maybe for 5 minutes they'll discuss something to do with the breast cancer. They really are very different to us. And so how do you explain it to people? As Greg said, someone said to him, well, where do you get breast cancer? And so one option might be to explain that it's an abnormality in the breast or the chest, and that it's called male breast cancer. How do you go about explaining those scars? I think that maybe you should say that a shark bit you. You can just say whatever you think is appropriate, and if people are really annoying you, please use the shark analogy. I want to let you know about a group called Support Crew. It's a New Zealand couple that realised that when you're going through breast cancer, you do need support. But how do you contain it, and how do you have all the information given to the people that you want to have the information? And so what Support Crew do is you choose who you want to be in your list, and it can be colleagues, friends, family, and someone else coordinates what goes onto your webpage. So they can give updates on when you're having surgery, how your recovery is going. And if you do need support with anything, maybe some lawn mowing or heavy work around the house that you'd normally do, you can put that on the list, and people just allocate themselves to jobs, so it's not onerous anymore. It can be really hard being a man, and what role do you play in the family? If you're the breadwinner, it can be really scary knowing that you're going to have to possibly take time off work. And how do you go with being the coordinator or the centre of your family when you know that you're going to have to commit to all this treatment? It's really tough. And so there's also issues to do with work. For some people, they work throughout their treatment. And if you really love your job and you find it a great distraction, then that might be what's right for you. But for some people, it's just too hard. One of the big side effects is fatigue, brain fog, and muscle strength. So if you have a physical job, that can make it really challenging. So my advice would be that you do need to be in really close contact with your boss and ask for flexibility. A lot of people with breast cancer like to know that if they do feel up to working, they can, but if they're not feeling up to it, that they have that flexibility of half days or a slow return to work. And I mentioned about the scars already. The other thing that's really hard about a cancer diagnosis is navigating the hospital system. And Wayne mentioned that men maybe don't engage with the medical system quite so well, and that's because it's complicated. There are many people that are involved in your treatment when you have breast cancer. The surgeon, the medical oncologist, the radiation oncologist, those are for the treatments, but then in order to help you with the side effects, you have other specialists involved, physiotherapists and lymphedema therapists. And we're really proud at Breast Cancer Foundation to say that we provide funding for those services. So within 6 months of surgery, you can get 4 free physiotherapy appointments or 90 minutes of lymphedema therapy to help with learning about the condition and how to self-manage it. I forgot to put nurses on the list, and actually we should be at the front because we are the adjunct that often when people come back from these appointments and they need to debrief, or they thought of the question once they left the room, or they were too shy to ask the question, that's where we really come into our own of being able to explain things. So when you wonder, who do I go to when all these people are involved? The main point of contact is always the surgeon and the breast care nurses that work with your surgeon. So for example, if you know you've been referred to radiation oncology, but you haven't heard from them, who do you call? If you give the surgeon, well, the surgeon's probably busy in operating theatre, but you give his nurses a call, they'll be able to check if that referral's gone through and make sure that you haven't fallen through one of the cracks that sometimes happen in our health system. This is the team of people that will organise your ongoing surveillance, and that's normally done on a yearly basis. Or if you developed a new symptom, which is terrifying when you get a new symptom, if you go back to the person that treated you initially, then at least they know about your history and they know how important it is to see you quickly. Treatment side effects. So we've heard Greg and Wayne talk about the different things that can occur. When you're recovering from surgery, there's another issue called cording, and this is where the lymphatic channels from having the lymph nodes removed become scarred, and that can really affect your strength and flexibility in your arm. Lymphedema is a chronic condition which is more likely to happen the more lymph nodes you have removed. Greg was telling me before that he's been very lucky not to be affected, but his friend has. So it can be quite random in regards to who it affects. But for those that do have it,
Can you just tell us a bit what it is, what
Yeah.
it looks like, feels like?
so lymphedema is when the body's not able to move the lymphatic fluid around our body in the same way because those nodes have been removed. And people will often notice that it started because they'll have a change in arm size. So you might notice it when you're putting on a shirt, or if you wear a watch or a ring, you might notice that it feels tight or uncomfortable. And so there's definitely therapies for lymphedema that involve compression sleeves, manual lymphatic drainage where you move the fluid towards the lymph nodes that are still in the body. And exercise is another really important part of managing lymphedema, because then the muscles are helping to move fluid around your body. People that have lymphedema talk about it being an everyday reminder that they've been affected by breast cancer. So it's really challenging. The interesting thing about radiation therapy that I hadn't considered with men is that they lose the hair on their chest. And that can look a little bit strange if you've got dark hair on your chest and you have hair on one side and none on the other. So I guess you could go and get the other side waxed. No, says Greg. Okay, because it's painful to have waxing, but that's something that's just another reminder. And for some people, that hair loss is permanent. And Greg spoke about the skin irritation that he had from the radiation. We all know there are lots of symptoms that go with chemotherapy, but I think the thing that's really important for men is if they are trying to work, how that fatigue and brain fog can really affect their ability to carry on with those tasks. We've also spoken about the hormone blockers, and once again, the brain fog features. And I think the sexual dysfunction is huge. This is a really huge component for men that I'm aware in the space of women, we talk about it a bit, but it must be very difficult for men to talk about it, especially outside of their relationship. Osteoporosis is another thing that you don't really think about in relation to men. A lot of women get it as they age, but the hormone blockers bring it on for men, which means they're more at risk of having small fractures. And so that's another challenge when you're wanting to carry on with life and be part of the workforce. And as Greg mentioned, he got road rage. Now, I would say that's because he moved up to Auckland, but he thinks it's because of the hormone blockers, and yes, it probably was. So that's really challenging, especially in a relationship. You know, you have to have an incredibly supportive partner and have really good communication. Genetic testing. So Wayne's talked about the different genes that are involved, and I know that internationally all men with breast cancer are automatically tested for a genetic problem, but in New Zealand that's not the case. The geneticists use a scoring system called Manchester scoring, and what it does is it calculates how likely you are to have a gene mutation. So they want to look at a wide range of things. Your family history is really important. As Wayne mentioned, there are specific cancers that people get if they have the BRCA mutation. And so if that's in your family, then that gives you a higher Manchester score. If you were younger or you had a larger tumour or one of those unlikely receptor types like HER2 positive or triple negative, then that's going to bring your score up. And that way they can use the resources appropriately and test people that are most likely to come up with a result. Now, part of the reason that we're using this scoring system is that we only have 3 centres in in New Zealand, Auckland, Wellington and Christchurch. And when we do genetic testing, we send them away to overseas laboratories where they have many more tests to do, and it's most effective when they do them in what they call a batch. So depending on when the batch of tests is going, the results can take anywhere between 4 and 8 weeks. Now this can be really challenging because if you have the BRCA gene, it might be that the surgeon offers you a bilateral mastectomy, so that means both breasts are removed because the chances of it coming back are a lot higher. So sometimes people will have that neoadjuvant chemotherapy first while they wait for these results. It can be quite complex, the pathway. But of all the genetic mutations or variants as they're called nowadays, BRCA2 or BRCA2 is the most common. Services for men at Breast Cancer Foundation. As I said, nurses are an integral part of your care, and it's because we get it. You don't have to start at the beginning and explain it because we know what your pathway's been. If you have felt that you've been stigmatised because you're a man in a big world of females and you want to talk about it, we're here. We're here to listen. We can explain the treatments that are coming up, tips for managing side effects and advice, and helping you to navigate our resources. We have a range of webinars, and good on you if you're listening to this one tonight. We save them and you can watch other webinars that are really relevant to going through treatment. So we've got webinars about managing side effects of chemo and radiation, how to manage the side effects of the hormone blockers. So all those things will be so useful for you to know what you're dealing with. And we're there to point you in the right direction. In regards to support groups, I'm going to do a plug for our own Breast Cancer Foundation support group. It's called MyBC, and it's an online chat forum. The thing that a lot of people like about it is that it's anonymous. So you can have a username, and if you want to pretend to be one of the girls, well, you can. The thing I like about it is that it's New Zealand focused. So you're going to have information shared that's specific to what's happening in New Zealand. And as a nurse, and what I'm doing each day is checking if people have submitted questions through MyBC or they've put forward a question to the community and it's not answered, I'll go on and make sure that they get an answer. Facebook has a lot of groups, and Greg mentioned that he has a group that he belongs to that's an international group. So you just need to be mindful that when you're dealing with international groups that practices that happen in America, for example, can be very different to what happens in New Zealand. If you do find out that you have the BRCA gene, there is a specific support group in New Zealand called the Gift of Knowledge. They're called that because they believe it is a gift to know and be able to plan and have the monitoring of other likely cancers. There's a Look Good, Feel Better program for men. So if you're losing your hair and you're feeling a bit down in the dumps, why not go and be pampered and learn some new techniques? They also have a really great giveaway bag. So you just never know what you'll get. And there's very strong research that exercise is essential in helping people to get through treatment and to stay free of cancer. So this, there is a group called Pink and Steel that the ladies would have heard because they go for the Pink rehab program, and Steel is specifically for men that have had cancer. So if you want to be with a group of men and also be with a physiotherapist who understands about cancer rehab, this is absolutely the way to go. They have great programs in place and they're normally free.
Great, thank you, Judith. And I guess one other thing which wasn't on the slide, but we do fund counselling services that are available to men too, don't we?
Yeah.
How do people access that?
And so all you need to do is get onto our website, breastcancerfoundation.org.nz, and if you click on the support button, it gives you an application form that you can fill in yourself and you self-refer for 3 free counselling sessions. And it's also worth mentioning that if you are diagnosed with the BRCA gene and you know that you're at risk and you're trying to make decisions about what to do, all our services are available for those people as well. So you don't have to have had cancer if you are having a preventative removal of breast tissue because you know you carry that gene. We will fund you for everything.
Great. Okay. Thank you so much. Thank you, in fact, to all 3 of you. We're now going to open up to questions. I just wanted to check in, Greg, with you something first. You mentioned your vitamin C treatments.
Yep.
There's usually sometimes there are issues around the timing of vitamin C treatment. So could you just tell us a little bit about that?
Yep. When I was having chemo, I explained to my oncologist that I was having it, and he basically said, as long as it doesn't interfere with my treatment. So because I was having chemotherapy every 3 weeks, I managed to get two infusions done in between my chemotherapy, but I didn't have it less than 5 days before. So it was always a 5-day break between having the vitamin C and having the chemotherapy. That was during treatment. And then at the end of my surgery and treatment, I then had a 6-week intensive vitamin C treatment where they really just try to flush, and that helped my white cell count to go back and help me through the whole treatment. So yeah, had to be managed in conjunction with the chemotherapy.
And I think actually also with radiation therapy, vitamin C can interfere with that as well. So definitely, you know, great for your immune system, but something really good to talk to your medical specialist about. Actually, that's a topic. We have a webinar on our website too on vitamin C with Dr. Marguerite Vissers, who's New Zealand's probably leading expert on vitamin C, and a more sceptical medical oncologist. So that's quite a fun, webinar to watch. So do check that out. And we also have another webinar on complementary therapies by a doctor that might sort of put that in perspective for you too. Okay, so let's move on to some of these other questions. You're about genetic testing, but first up, just a question about chemotherapy, or really a comment from Lee, who is another man who's had breast cancer. And he says that he had a mammoprint test to help him make a decision about whether or not to have chemotherapy. He had to pay for it himself, which is a shame. But that gives you a prediction of how much benefit you'll get from chemo. Wayne, could you tell us a bit more about that?
Well, I'm not an oncologist, Adele, but I am aware of some of these predictive tests like mammoprint and Oncotype DX and the PAM50. There's about 4 or 5 of them now that we use, and they're particularly good in that grey area where people might not be sure if chemo is for them or not. So some people it's black and white and other people it's grey. And if it's grey, those tests may be useful. I don't think any of them have been proven in the sphere of male breast cancer, and that's you know, the issue with them.
Yeah.
But it may be a reasonable thing to use.
So once again, you'll be kind of using the women's data. to
Yeah, using the
decide,
women's data.
How accurate that is, yeah. And I think those tests generally cost $3,000 or $4,000. So it is quite a significant amount of money. But
and I think they generally have to be self-funded.
Yes. Yes, and sometimes for most of them, I think the testing's done offshore, so it takes a couple of weeks.
Yeah, that's right.
But something to talk to your medical oncologist about. Yeah. Okay, thank you, Lee, for asking that question. Now, a question for Judith. Judith, should men be self-checking if they haven't had breast cancer and they don't know their risk, the general population?
Absolutely. That's a really great question. And one of the things that we really promote at Breast Cancer Foundation, and the poster behind me says it all, know you're normal. So, yeah, if you know what's normal, and then you will definitely pick up when something is abnormal. And I guess men find it a lot easier because they don't have those hormone fluctuations that women do, where their breasts will become sore and lumpy at different times of the month. So the best thing to do when it comes to male or female breast examination is to be systematic about doing it. So it's covering the whole breast area, including the underarm. And one method that seems to appeal to men is the lawnmower method. So you're just going to go up and down in strips. Yep, that should be good. Go and mow the lawn. I was working on our pink caravan one day, and a lady came up to me and said, my partner's got a lump, and she grabbed my hand and put it down his shirt, and absolutely he did. He had a lump, and I said, you need to go straight to the doctor. So just also be mindful that when you're in a relationship and your partner feels something, take it seriously, support that person to get to the doctor.
Okay, question, let me see, another one for Wayne around the BRCA2. Do you know how many of the 25 males diagnosed with each year have a breast cancer each year would have a gene mutation?
Gosh, I don't know the exact figures, but it's probably in the order of about 10% of them. It's a low figure. But if you've got the BRCA gene, that's important.
But higher, obviously, but higher than the female breast cancer patients, more likely, men are more likely to have that BRCA mutation. Yeah. And so someone has asked us, a woman has asked us about her. She carries the BRCA2 gene, and she has two sons, aged 26 and 28, who haven't been tested. What would be a wise path for them to follow? I'll start with you, Wayne, on that.
Yeah, well, I suppose the first thing is have they had a discussion about what the BRCA genes are and the implications of it? I think that's the first thing. Certainly, a lot of people delay discussing those sorts of issues with their kids till they're an age where they can understand. So you've got to make those decisions. And I think probably, as Judith said, the main thing is breast awareness. And they should be encouraged to check for lumps. There's no role at the moment for routine breast image screening in men in that situation. But classically, men are easier to examine than women. And if there are any concerns, they need to see the doctors.
Great. Okay. And so, Judith, what if you're not in Auckland, Wellington or Christchurch? Can you still get a genetic test? What?
Absolutely. So the process is that a health professional needs to send the referral to the nearest genetic hub, depending on where you live. And so the more information on the referral, the better. If you go onto our Breast Cancer Foundation website, we do have a page called Inherited Risk. It explains things beautifully, and it has a link directly to the Genetics New Zealand webpage. And one thing I always recommend is filling out the family history cancer questionnaire. So if there is a known carrier of a gene in the family, then you'll get a much higher Manchester score. If you can gather all that information and it goes along with the referral from normally it's the GP, then hopefully you'll get a high enough score that you'll then be seen by the nearest genetics clinic. And although we talked about 3 different cities that they're based in, they do have satellite clinics. So they do move into the regions to do clinics.
Can I just add that I went through that process. My mother had cancer of the inner ear, so that gave me some points. I had female siblings, nieces. So my family was quite concerned that I didn't have, well, they needed me to be checked for BRCA. Completed the questionnaire fully. I obviously got a sufficient score because I got a very, very comprehensive genetic report back from these people, which was very valuable, not just for me, but my entire family would now rest assured, and my nieces at the age of 18 can go and get checked if they need to, because they're aware, but I didn't have the BRCA2, so it's their choice.
Great, great.
And another thing with the genetics in a situation like Greg's, where it's come back negative, or if you're declined because you don't have enough points, when something changes in your family and another family member gets a diagnosis, it changes everything. And so people that haven't been tested before will suddenly be eligible for testing. And in some cases, it can be every 5 years that they can retest a sample because new things are discovered.
Great. And that BRCA gene can be passed on to sons and daughters and from fathers and mothers, isn't that right?
Yes,
So,
that's right.
And if people don't know their family history, or if there's no one still alive to...
Well, thankfully, the Manchester School takes that into consideration.
Right.
So if you were adopted or your family members passed away before they had a chance to explain family history, you will get some points for that.
Great.
And Adele, we talked about the BRCA genes, but we think probably half the genetic causes of breast cancer are other genes as well. And they can be tested for now when they do polygene assays.
Oh, great.
And there may be some relationships with different genes that may account for some changes as well. So it's an ever-changing field.
Yeah.
Yes, that is very true, and the criteria has changed a bit too. So I would say to any man who was maybe diagnosed maybe more than say 10 years ago, say before BRCA testing was as available, you might actually want to have a talk with the Genetic Health Service about getting about whether your family does actually qualify, because they won't have gone back to you. If you were diagnosed 10 years ago, you're sort of not on their radar. But if you do have a concern, start talking to them. And those tests have got more sensitive too. So even people who were tested 5 or so years ago might find that the tests are more sensitive now, if their family history is strong enough to make them think there really is something going on there. Okay, couple of other things. Can men join clinical trials, Wayne?
I'm not aware of any. Because again, the numbers are so small and they try to make the trials as homogenous as they can.
Right.
So I'm not aware of any male breast cancer trials, and they're not, for the majority of the drug ones, you need to be female.
Right, yeah, so that's another reason why we don't have that data if we can't run those studies. So that's a bit of a tough situation there. Okay, Greg, what did you find most helpful throughout your treatment journey, and what were there a couple of things that you would say were of particular use to you, whether it's information or people or?
Keep exercising. I know Judy's covered. I actually was going to the gym even during my chemotherapy, as pathetic as it was, but that kept me a bit of sane behaviour there, so that was useful. I think the health service itself, which I mentioned in my presentation, that they were very supportive, so I could always find somebody to get help, to get dressings and whatever. But I think the thing to me was mentality. It's remaining positive. I went to so many clinics, especially with people with lymphedema, who were sitting there, the body was hunched over, they got a big arm or a leg or something, and you could see that their demeanour was really damaged. That's the right way of putting it. And the one thing that kept me going was I was actually part of the Scout movement. I was actually doing community patrols. I tried to keep, although I was retired, I kept going. And then towards the end, I've now qualified as a Justice of the Peace, even when I was taking tamoxifen. So I actually worked my way through the foggy brain and whatever and passed the exams. So I think all I would say is, to sum all that up, is it's all up in your head. You know, the more positive you can attack the treatment, it is a treatment, the more you can stay on track with your life, and to Judith's point, your work and your relationships and whatever. You've got hurdles, you've got issues, but to me, the positivity of attacking this is key.
I can't agree with you more, Greg. I see that all the time.
Yeah.
The people who are positive are going to fight it, and but also maintain a sense of normality.
Yeah.
Have a normal type of timetable.
Yeah.
Normal relationships. They do much better.
Yeah.
Do much better long term. And they can cope with the treatment better too.
I think that's true. I was saying earlier, I did a pink walk the day after my first chemo in Tauranga. I walked 1.5 kilometres dressed up pink with the rest of the ladies. So I think you're right. It's so important. I'll stop there.
Great. No, that's very helpful. Thank you very much. Now, a question around the androgen therapies that you talked about, Wayne. Are they funded? Do many people get those?
They are funded, but they're not first line. So
Right.
first line treatment is tamoxifen and the chemotherapy. And then if the cancer does come back, the androgen therapies are considered.
And a question about tamoxifen, can it lead to a lowering of your platelet count?
I've never heard that. It's not one of the side effects I know of. It can actually increase the risk of blood clots in the legs. And that's why we say people need to be careful when they're doing long distance air travel.
Right, yeah.
Now that we're starting to fly again.
Yes, that's right. A good problem to have in a way.
I have to take low molecular heparin injections into my stomach if I do long haul.
Yeah.
Right, okay.
And that's partly because I've got slightly thick blood, but the tamoxifen exacerbated that. So I do actually have to take a precaution before I go on a long haul flight.
Interesting. And here's someone who agrees with you, Greg, around the attitude problem. Says, my wife didn't let me feel sorry for myself, even though I had dark moments. So good on you. It's
Brilliant.
good to know someone's looking after you like that. Now, question around how do you know if your breast cancer might have come back, which is a real worry for some people? Wayne, what are the signs that you would tell
Yeah,
people
so there's various places it can come back. It can come back locally on the chest wall. So that's really a case of keeping an eye on the chest and examining yourself and having regular checks. And certainly, just as with female breast cancer, we're very keen to follow up our patients for 5 or 6 years or so to make sure they don't get those sorts of problems. Checking for lumps under the arm, so those are the lymph nodes. And if they develop new symptoms, backache or shortness of breath or headaches, they need to report those things to their healthcare professionals and get appropriate investigations or referral and tell people that they've had breast cancer.
Right.
Because again, it's not going to be at the front of the GP's mind.
Quite so. And I think perhaps a persistent cough can sometimes be a thing too. So yeah, I think, yes, talking to the GP and asking for a referral back. Judith, would you say to the breast clinic or?
I spoke to somebody recently who was still in contact with their surgeon, and so they were able to go straight back to their surgeon and bypass the GP. But on the whole, the GP is a person to go to if you don't have that relationship with the breast clinic.
But as Wayne says, remind them that you have had breast cancer. Yeah. And we do have another webinar about fear of recurrence and signs of recurrence on our website too. So that might be helpful for some people. See, we've just got our last few minutes, so let me see what else we've got to ask for here. Judith, advice for men's partners about how they can help their man through this. advice?
I think it's for anybody that has a cancer diagnosis, going to appointments and hearing medical information is very overwhelming. You're basically learning a new language, and so always go with that person to their appointment so that a second pair of ears is hearing the information. And I think it's be guided by the person. Some people want to talk about it, other people don't. Some people don't want to be treated differently. They still want to have the same roles within the family as much as they can. I would really strongly encourage counselling if there does become communication issues, but try and communicate and just ask what that person wants, and understand that sometimes when their mood is not good, that try not to take it personally.
Now, someone who says, I've been to my GP about a lump, and he said, don't worry about it, but I'm still worried. It's a tricky one, isn't it? Because GP is an expert, and yet we might feel that something's still wrong.
The trouble is the GPs don't see many breast cancers. And so I think in that situation, that person should ask for a referral to the breast clinic.
Right, yes.
And all towns and cities have access to breast clinics.
Right. And perhaps if the GP is not willing to do that, see another GP, or go to your local after hours clinic or whatever.
Yes, you could.
Yeah. Great. And certainly we often say to women, don't we, that if your instincts are telling you there's something wrong, then don't let it go.
Yes, absolutely.
Great. Okay, let me just see what else we've got here. How many men get reconstruction, Wayne? How common is that?
Not very common. I suppose I've done about 3 breast reconstructions for males, a couple of chest wall implants,
Right.
and a couple of those men have had nipple areolar complex tattooing, and that can be very, very effective.
And is there any sort of specific circumstances where that seems to be more?
Well, certainly for younger men who are perhaps more physically active, take their shirts off, want to go to the beach, have got running around with the little kids.
Yeah. Great. How do you feel about that?
I thought about it and decided didn't really want to. I subscribe to Judith's view, not the shark attack. I say the other guy in the knife attack came off worse than me. Okay. It's a scar on my chest. It's an operation I've had. I take my shirt off on the beach, and I've been in swimming pools, and I just live with it, and it's just part of me now. I have thought about having a tattoo over it, but then didn't. But it's the scar is part of me. So I don't really need to do anything about it. But for those people who do, I can take to Wayne's point. I guess there'll be some people who do want to have that done, but it's me now.
Great. I actually think that's a really lovely place to end, and we are right on time. So thank you very much for that. In fact, thank you all of you, Greg, Wayne and Judith, for your time. And Judith mentioned connecting into MyBC, our online community. You've got the details there on your screen, and we'll see you next time. Good night.
Bye.
Bye.